Hi, everyone. Welcome to our panel today on International Overdose Awareness Day. We will wait for a couple of minutes for others to join in, but thanks for giving us your lunch hour today. Great. Hello, everyone. Thanks for joining us today. My name is Sadaf Kazi. I am a research scientist at the National Center for Human Factors in Healthcare at the MedStar Health Research Institute and assistant professor in emergency medicine at the Georgetown University School of Medicine. I conduct research on opioids using human factors methods and currently lead a grant funded by the DC Department of Behavioral Health on screening and treatment of pregnant and parenting individuals for opioid use disorder in DC. So we have organized this panel today on International Overdose Awareness Day, which is observed annually on August 31st to remember people who we have lost to drug overdoses without stigma and to raise awareness about how to prevent overdose deaths in the future. Substance use and overdose deaths have been increasing throughout the COVID-19 pandemic, and therefore it's more important than ever to discuss what exactly we can do to help our communities in DC and nationally to tackle this serious public health problem. At MedStar Health, we recognize that this problem is very complex, and it is important to have a collaborative and multidisciplinary approach in managing substance use and drug overdoses. So today we've put together a panel that features experts from the fields of pharmacy, community-based health, emergency medicine, behavioral health, and research. Our panelists are embedded in MedStar Health's operation and research work in the area of substance use and overdose prevention. So today we are joined by Dr. Bonnie Levin, who is the Assistant Vice President for Pharmacy Services at MedStar Health, Ms. Diana Quinn, who leads the Community Health Department at MedStar Health, Mr. Ian Bond, who is a peer recovery coach and a patient in recovery at MedStar Washington Hospital Center, Dr. Marianne Amirshahi, who is a practicing physician at the Emergency Department at MedStar Washington Hospital Center, and a professor in emergency medicine at the Georgetown University School of Medicine. And finally, Dr. Mihire Mete, who is Director of Behavioral Health Research at the MedStar Health Research Institute, an Associate Professor in Psychiatry at Georgetown University School of Medicine. So we have a great list of panelists, and we will kick off our panel by first learning how exactly MedStar Health approaches the issue of substance use and overdoses from a multidisciplinary perspective. So I'd like to begin by welcoming Dr. Bonnie Levin. Dr. Levin, thanks for joining us today. I was wondering if you could talk to us about your role at MedStar in general and focus on what you do in the field of substance use and overdose prevention.
Well, thank you, Sadaf. I am honored and privileged to be here today and to help kick off this panel. I am the Assistant Vice President for Pharmacy at MedStar, so responsible for basically all things medication related at our hospitals and ambulatory areas, as well as our community pharmacies. Pharmacy role at MedStar to manage substance use and overdose prevention is very collaborative. We have an opioid stewardship subcommittee that's been active for about 5 years that is very multidisciplinary. multi-specialty. We hit all levels of care. So we have lots of providers, nurses, informaticists, and others who work with us to help design optimized policy and guidelines and such. We also have a Pharmacy and Therapeutics Committee that has responsibility for policy and medications for all areas and is active working with the Opioid Stewardship Subcommittee. So specifically, pharmacy is involved in developing and managing clinical practice guidelines, formulary, policy, and all of the technology around use of medications, specifically for opioids, medication assistance therapy. Decision support, which is working with our electronic record, MedConnect, to have rules and alerts that guide the providers and nurses to do the right thing with opioids and to make it harder to do the wrong thing. So we work with them to reduce unnecessary opioid prescribing, to identify and prevent drug interactions with other medications that could increase the risk of overdose. In terms of overdose prevention and opioid use disorder prevention, we've worked very hard with prescribing issues to limit the amount of unnecessary pills out in the community. We call that the pill burden. So we've worked to with a number of surgical subspecialties to identify the right number of pills you need if you're having surgery, so that you have enough but not too many, and the rest are not sitting on the shelf at home at risk for someone to take and abuse. So we have more than 50 different surgeries we've identified and defaulted into our record the right number of pills. We've also worked with long-acting opioids to really try to restrict their use to appropriate patients with chronic pain. So cancer patients, hospice, palliative, sickle cell, and make it really hard for these medications to be used in areas which would put patients at risk for overdose or abuse. We've also continued to work to reduce the number of unused doses at home by putting take-back units in most of our hospitals and making them very accessible for patients and our employees as well. And if you're not familiar with them, they kind of look like a mailbox where you can put in unnecessary prescriptions, no questions asked, no paperwork, and it's a really good way to get them off of your shelf at home from the medicine cabinet. We've also dispensed packets, over-the-counter packets, to help you deactivate medications that you don't need. It's a little bit like kitty litter. In a vial of medications, you put in this packet of powder, add water, and it creates kind of a clay to deactivate these medications. Again, all ways to reduce the amount of unneeded pills at home and therefore the risk of them being abused. Importantly, we've made naloxone or Narcan very accessible for our patients, both when leaving the emergency department if they came in for an overdose or abuse. And we often are able to dispense it at no charge to patients who need it. And we've also developed in our medical record a way to remind providers to order naloxone for patients who they're sending prescriptions to. We've done extensive training for our providers on how to use medication-assisted therapy, and I think others will probably talk about that. And finally, I have to mention, very active in drug diversion prevention, because we know that our associates have access to controlled substances, and we want to be sure that they're not abused. So we work very hard to quickly identify any employee who may be abusing so that we can provide education, treatment, referral, and also prevention services. I think we'll probably talk a little later about the medications that are used for medication-assisted therapy, but we do have them at MedStar. So buprenorphine comes in a number of different forms. In combination with naloxone, it's also available for both induction and maintenance. We do have methadone, which is used for both as well. And so with that, I think I'll pause and let others go, and then hopefully there'll be some questions at the end.
Great. Thank you, Bonnie. That was a really good overview of all the things that the pharmacy department is doing at MedStar. I wanted to follow up with some questions actually about the medication-assisted treatment. So can you give a little more detail about that? And then we'll also ask our other panelists to talk about their experiences with MAT.
Yeah, so it's an interesting group of drugs. So there are both agonists and antagonists that are used. So buprenorphine is probably the most widely used and maybe the newest. Trade names are Sublocade when used alone. In combination with Narcan, Suboxone is also very common. They're used to both primarily for maintenance of prevention of reuse. And it's typically given sublingually. It's a little film that you put under your tongue, and it's given daily. So it's not very obtrusive. Patients can take it. It's readily accessible, and it can't be abused. So, some of the medications can be ground down and then injected. This cannot be. So it really is a prevention. Methadone has long been used for maintenance and is available from clinics. We use it on the inpatient side when patients are treated in a clinic. And it is restricted, as I said, it's restricted to certified programs. Buprenorphine alone is used for, actually it's used for pain in some cases, but also for induction and maintenance, depending on the route of administration. Again, sublingual, but also available in a transdermal patch, a skin patch, which again is also not very visible, which is good. And also a long-acting implant that's injected under the skin and lasts for up to several months.
Great. Thank you for that really comprehensive overview of what medication-assisted treatment therapies are available for opioid use disorders in general. So thanks for that, Dr. Levin. I'd now like to move on to our next panelist, Ms. Diana Quinn. She is the Director of Community Health at MedStar Health and leads a group of peer recovery coaches who are patients in recovery from drug use. So Diana, welcome to the panel. Thanks for participating. Can you talk to us a little bit about your role and what you do in your role for substance use overdose prevention at MedStar Health?
Good afternoon. Thank you so much for having me. I'm delighted to be here today. So I am the Senior Director of Community Health at MedStar Health. My role is to oversee community health programs and which were prioritized through our community health needs assessment. So in 2018 and our most recent assessment in 2021, behavioral health and addiction has really bubbled up to be highlighted as a health priority that MedStar should be looking at. And it really supported our response to the opiate crisis. We looked for innovative programs, different partners to work with as we wanted to address this, especially in our emergency departments. So we worked with a Mosaic Group to launch our screening, brief intervention, and referral to treatment program. This was a program that provided universal screenings for adults in the emergency department. And based on that screening, there would be a score and it would alert one of our peer recovery coaches to conduct a brief intervention just to identify and to assess where this patient is in their journey of addiction and to assess their readiness to change. And as part of that program, our peers do a brief intervention. Again, it's a chat, a conversation, informal. And based on the needs of the individuals, we can refer them to treatment, either long-term or something local in their community, just to help them address their concerns. So from there, we piloted our program in 2016 in Baltimore City. And since then, we have now scaled the program to all 9 MedStar acute emergency departments across Maryland and Washington, D.C. But beyond our emergency departments, the program has just expanded and just grown and is well liked throughout the system. We have a field-based program, which is a peer recovery coach out in the field through our Overdose survivor outreach program. We now have peers in women's health, mother-baby, and now also in the outpatient behavioral health center. So you can see that the program has just grown so much. The program is system-wide. We've hired nearly 40 peer recovery coaches, which is a new population health workforce for MedStar. So nearly 40 across the system. And just last fiscal year, just to give you a little bit of numbers, we conducted over 250,000 expert screenings in the emergency department.
That is very impressive. Thank you so much for giving that background. And it looks like there is a really great community health program that we already have in our system. I was wondering if you can talk a little bit about what the job of a peer recovery coach looks like. What are their roles and responsibilities?
Yes, I had the pleasure of hiring our very first peer when we started nearly 5 years ago. So our peers are a brand new non-medical population health workforce. They are members of our local community. They are in long-term recovery. And the reason that their role is so important and vital to this program is because they have personal lived experience. They can share their journey, their challenges, their experiences, and can relate better than someone in a white coat, especially during those brief conversations during the brief intervention. So that really makes the ultimate difference. We have men, we have women that serve across our system. And it's just been a joy to see them integrated within our clinical teams in the emergency departments and really become part of the care team. So it's been wonderful to see the growth of the program, but more importantly, just seeing how our peers are integrated now within the system.
Great, thank you so much. So it sounds like a really good resource that MedStar Health has in integrating peer recovery coaches, and that actually is a great transition to our next panelist, Mr. Ian Bond, who is a peer recovery coach at Washington Hospital Center. And welcome to the panel, Ian. Thanks for joining us today. And if you can talk to us a little bit about your role at MedStar, help us understand what it looks like on a day-to-day basis. Oh, you're on mute, Ian.
I apologize. I'll start over. Thank you for having me. I'm grateful to be here. And I always say that I'm grateful. And the reason that I say I'm grateful is because I'm grateful to be alive today, because I am a drug addict and alcoholic in recovery. And being a peer recovery coach gives me and my colleagues and everybody else who does this job the ability, when a patient comes in, whether they come in under the influence or whether they admit to substances, we go and have a brief intervention with them. We talk to them, we ask specific questions, and we find that sometimes they open up to us a little bit because they understand that we've lived that life. We come from where they come from, so that's why it's a peer. And the other side of that is that what we do is we ask, what's their plan? What would they like to do when they leave the hospital? What's their goal? And we have so many different options for patients, whether it's outpatient, whether it's inpatient, whether it's resources for AA meetings, NA meetings, and even more so, Oxford housing, if they don't have a safe place to live, if they need a safe place to live, to start rebuilding their life, depending on where they are in the state of change. And the other wonderful thing is that, as other peers have mentioned and people on the panel have said, is that we have the MAT, that we can help them with their substance abuse, whether it is getting them connected with a methadone provider, whether it's getting them connected with Suboxone. And one of the beautiful things that we started here is Unity Health, where if a patient comes in before they leave the hospital, we can get them connected and have a prescription waiting at the pharmacy. Because one of the most important things, and I say this from my experience in being on Suboxone at one point for 5 years, is that you don't want them to go through withdrawal, because when a patient goes through withdrawal, that's when things can happen. So if they know that as soon as they leave the hospital, that they're going to be able to get that medicine to help them get on that path to recovery. And we also, in addition, we follow patients from the ED up onto the floors. So if they get admitted, we follow them up and we check in on them on the daily. And we also work with the doctors, the case managers, the social workers, the nurses. It's all collaborative. It's all a team effort, which is really nice. And I have found nothing but my experience here at MedStar to exceed my expectations and be absolutely wonderful and welcoming. It's as I say, I found what I was meant to do with my life, which is to help other people find recovery, because I always believe that there's hope, and I never think that it's too late.
Thank you so much, Ian. We are very lucky to have you work in our healthcare system, make a real difference to patients' lives. Before we jump to our next speaker, I was wondering if you can also talk a little bit about how your experiences as someone who's in long-term recovery, how that informs how you connect with patients on a daily basis, how you work with them, the types of conversations that you have with them.
Of course. So being both a drug addict and an alcoholic, depending on the substance that they come in on, I know what it's like personally to go through withdrawal. I know what it's like to at some point be homeless. I know what it's like at some point to not have family members in your life or to push them away. So when I'm talking to the patients, you know, I'm hoping that they can relate to me, because if they're going through withdrawal, I get it and I feel it and I remember that. So I can talk to them and let them know we can get you comfortable. We can get you to a safe place. I mean, that's the whole thing about being a peer, is that I walked in their shoes. You know, one of the beautiful things that I found for me is that being in recovery, when I see a patient who comes in, I look at me. I see me. I see me when I was in active addiction, and I see me that if I don't stay in the center of my program. So, you know, it's something that every day I believe that there's hope and I can get them connected no matter what it is. And it's just being able to relate to them and understanding where they are, no matter where they are in their journey, being able to help them.
Thank you again. I am sure you bring so much empathy and sensitivity in your role, and we cannot thank you enough for actually helping, making a difference in DC and just in MedStar Health in general. So thanks again, Ian. Now we'll move on to our next panelist, Dr. Marianne Amershahi, who is a physician in the emergency medicine department at Washington Hospital Center, and also a professor at Georgetown University School of Medicine. So welcome, Dr. Amershahi. Thanks for joining us. If you can just talk to us about your role at MedStar, specifically in emergency departments, and what you do in that role for substance use and overdose prevention.
Well, thank you so much for having me. It's a great opportunity to talk about some of the things that I'm most passionate about and that have really shaped my career as a physician. So I'm going to say that I have a varied background and I wear a lot of hats for MedStar. So a little bit about me: before I went to medical school, I was actually a pharmacist. Additionally, I'm a board certified medical toxicologist and an addiction medicine physician. And so I think my first role at MedStar really stems back from my days as a pharmacist. I started as a pharmacist around 2000 when there was this big push to prescribe prescription opioid analgesics. And while I was working, I saw the number of prescriptions just skyrocket and the pills were flying off the rack. And so how this relates to what I do at MedStar currently is I kind of go back to my roots in that really we work on prevention, and that means a few things. So with my position on several committees that Dr. Levin had mentioned, such as the Opioid Stewardship Committee, the P&T Committee, is that I help to design protocols, particularly for the emergency department, for what we call ALTO, or opioid alternatives, so that we minimize opioids and we use other non-opioid agents that have kind of evolved and taken on new roles to help manage our patients' pain, such as ketamine and lidocaine. Additionally, we've been involved with some of the ED opioid stewardship programs, in that we actually work on prescribing and administering less addictive opioid analgesics. So for example, in the emergency department at our hospital, we have limitations on hydromorphone, which is known to be a more addictive opioid compared to morphine. So in most patients, we preferentially give morphine, for example. And so we also monitor the amount of opioids that we prescribe from the ED, because we do work in a specialty where we are encountered with acute painful conditions on a daily basis. So that's my first role. The second role is loosely affiliated with MedStar, which is through the National Capital Poison Center. As a medical toxicologist, I write our guidelines for our poison center, and I help provide consultation for providers that call us from the area that need assistance with managing overdoses. Additionally, I work on educating our poison specialists to help them optimally manage our calls about opioid overdose, but also withdrawal management as well. The other thing that I do is I'm very active in research, and that has taken the form in a lot of different things during the course of my career. I've actually written and published in peer-reviewed journals dozens of papers, specifically focusing on opioid prescribing, opioid stewardship, overdose, addictive potential of opioid analgesics, naloxone, as well as the current concerns with fentanyl tainted heroin. Most recently, we actually published a paper that just published online this month that looked at our SBIRT program in the ED, which I'll talk about in a minute, and how our substance abuse screens and acute overdose presentations were impacted by the first wave of the COVID epidemic. We also are looking at the Unity LinkMat intervention that Ian referred to, and Dr. Mete will talk a little bit more about that. The other thing that I like to think that I do at MedStar is mentorship. So for example, our most recent publication was actually first authored by one of our medical students. And myself and Dr. Mete have been actively involved in mentoring residents and medical students to get them involved in substance abuse research. The other thing that I like to do, is education. So I not only educate the poison specialists that I work with, but I give lectures to our residents, which are through the Georgetown Washington Hospital Center residency programs. I also teach about substance abuse and addiction to paramedics, to our nurse practitioners and physician's assistants. And on every shift, I always say to our medical students and also our new residents, because it was recently July, I always send them Ethan's way. And I said, you know, we have this great resource. What do you know about addiction? And on every shift, we always encounter somebody that is overdosed or has a problem with substance abuse. And so I use that on every shift as a teaching opportunity. The final thing that I do is I'm kind of the boots on the ground ER doctor. So I have been really the point person because of my expertise as an addiction medicine physician in helping to implement our take-home naloxone in the emergency department, our program for initiation of buprenorphine, our LinkMat program, and more recently, I've taken on a role assisting with the DC Hospital Association to help move our medication-based therapy, such as initiation of buprenorphine for inpatients into Washington Hospital Center and MedStar as a whole. And I think that's about it.
That is really great to hear all of the different lenses and expertise that you bring to the problem. It was really great hearing about all the policy work that you do, not just clinical work as a physician, but also how your past experience as a pharmacist inform your work, and of course your research that you're currently active in, as well as mentorship. So thanks for going over that. I have a couple of questions, but I just like to pause and say, if people have any questions, please feel free to use the Q&A button and just leave questions in the chat. And then we have some time at the end where our panelists are able to answer questions. So Dr. Amir Shahi, I was wondering if you could give some insight into if a patient comes in the ED with an overdose, how does treatment look like for that patient?
Specifically for an opioid?
Yeah, it could be opioid or it could be any substances that you encounter in DC.
I think that for, the opioid is probably the best example because we have a lot more treatment options. And I just want to say that I couldn't do half of what we do without Ian and the rest of our peer recovery coaches. So essentially the first thing that we do, and this has kind of been a shift in emergency medicine, because when I started my career, we literally stabilized the person, made sure they were breathing, and said, stopped that and sent them on their way. And then it evolved that we started offering more and more services, which has really been wonderful. So if we have a patient that comes in that has an opioid overdose, first and foremost, we have to stabilize them. That's the most important thing. And then once the patient is stable and able to talk as the drug is wearing off, we assess them, make sure there's nothing else that we need to deal with, and then we'll have a brief discussion with them, and also the peer recovery coach will then see them for a more in-depth discussion. At that point, we can do a few things. So some of our patients say, hey, Ian, thanks for talking to me. I'm not interested. Let me just go on my way. And those patients, we still give them take-home naloxone, and we show them a video on how to use that because we know that bystander naloxone saves lives. So everybody gets that. The second thing that we may offer them is to say, hey, do you want medication-based treatment? And some people have different feelings about being on long-term medication. So some people opt for acute detox. But the great thing is our peer recovery coaches are sometimes able to get patients into an acute detox where they basically just rapidly detox the patient, but they're not on maintenance medication long-term, the same day or sometimes the next day, and they'll even put them in a cab to get them there. The next option is methadone. Some of our patients, just because what we're seeing now is a lot of the heroin in the district is fentanyl. And we have some patients that actually prefer fentanyl, and sometimes they need a stronger medication such as methadone, or they prefer it because it's worked for them in the past. Our peer recovery coaches, most of the time, are able to get a patient into a methadone clinic the next day. And then finally, buprenorphine, which is one of our bigger pushes. So if the patient wants buprenorphine, we have a couple of options. If they are in enough withdrawal, we can actually administer a dose of buprenorphine right there in the emergency department to help make them more comfortable. If they are not in enough withdrawal, we have a few options. One of the things is our program with Unity, where essentially they do their first telehealth visit with a buprenorphine provider before they leave the ER. And if they're not enough withdrawal, they can give them a prescription. They'll give them a prescription anyway. But with that prescription, they will give them instructions for a home buprenorphine induction, which can be done safely, okay? And then they'll set their next follow-up visit. So the barrier in most instances to making that first appointment is eliminated. And they're also doing that now for patients that are being discharged after an inpatient stay on the day of their discharge. So less patients fall through the cracks. And then finally, whatever treatment option they are given, we give them a take-home naloxone in their hand before they go.
Great, thank you for that overview. So it sounds like it's a really comprehensive treatment program. You're able to screen people, but also treat them, and more important, just meet them where exactly they are in their recovery. If they may not be prepared right now, they may be prepared later, and we are prepared as a healthcare system to deal with all patients wherever they are in their recovery journey. So thanks again, Dr. Amir Shahi. Now we move on to our next speaker. I'm also seeing questions come in on the Q&A, so I encourage others to continue putting their questions in, and we will get to them soon. I'd like to welcome Dr. Mir Mete, who is Director of Behavioral Health Research at the MedStar Health Research Institute, and conducts a lot of research on behavioral health, opioid use, and the SBIRD program at MedStar Health. Welcome, Dr. Mete. Thanks for joining us on this panel. If you can give us an overview of your role and what you do in your role for substance use and overdose prevention.
Sure. Thank you, Sadaf, for organizing this panel and for having me. So this is great to get a chance to speak about what MedStar Health Research Institute is doing in terms of research on this important day. So I thank you for that. I am the Director of Behavioral Health Research. And as you know, behavioral health is a broad field. So when I took on this role about 2 years ago, I determined or designated substance use as one of the major research areas that I wanted to focus on. And you heard from my colleagues about the SBIRD program. I also served for a long time at MHRI as the Associate Director of Biostatistics Department. So that's where I got actually familiar with the SBIRD program when we started to explore the vast data resources MedStar has on emergency department screening, brief intervention, and referral to the treatment program. So SBIRD has been a gateway for me to start thinking about how we can leverage our data to improve our services and to better help our patients during a vulnerable phase in their lives. I started to collaborate with Dr. Amir Shahid, and we partnered with Unity Health and the Mosaic Group right before the pandemic started. And we developed a telehealth proposal. This study is called Linkman. Actually, it has been referred to by previous panelists, and it is an extension to SBIRD in the DED, where we try to connect individuals who are interested in joining a treatment program to an on-call Unity Health provider to get them a prescription before they leave the hospitals. So this intervention was funded by the DC Department of Healthcare Finance, and the intervention has been incorporated into the workflow now in the Emergency Department of Washington Hospital Center. And as Ian mentioned, it's been working well so far, and we are hoping to continue that intervention in the near future. So this has been an important project and intervention because we believe that connecting patients to treatment while they are still in the hospital is maybe a critical window of opportunity to get them started in treatment and hopefully remained in treatment. MedStar has always had clinician investigators who work diligently to help their patients with substance abuse. But my goal as the Director of Behavioral Health Research is to foster more targeted collaborations within MedStar and establish partnerships with external organizations in the community. So within the Linkman Study context, actually, we have improved our relationships with the Unity Health and also Mosaic Group. Mosaic Group has been very instrumental in general for the implementation of SBIRD and also in the implementation of our Linkman intervention. Overall, for substance abuse as a research department, our contribution to in this area, I'm hoping will be that to foster these collaborations, to do more research, to understand our MedStar data, and also to partner with DC organizations that are interested or might have common interest to find common solutions to combat this opioid epidemic and prevent overdoses.
Thank you, Dr. Mehta. That was a great overview of all the research that you do in behavioral health. I have one follow-up question. So I think you gave a really good overview of how you work with the emergency medicine department. Are there other departments at MedStar that you collaborate with, other researchers across MedStar, across DC in general?
I will start with MedStar. MedStar has initiated a research collaborative on opioid a couple of years back. So we have an interested group of investigators at MedStar who want to do research in this area. And for me, Diana has been very supportive and facilitator of the research. She got me access to SBIRD. She showed me the way, and she's introducing me to our community partners. That's my way of getting to know the groundwork. So as a researcher, I'm not very familiar with the clinical aspects of substance abuse, and I'm just getting to know the other community members who are active in this area, and some DC government organizations and Department of Behavioral Health and then Healthcare Finance that are really actively doing initiatives to help the community. So I'm hoping that MedStar soon will be one of the very important players in the field, in addition to SBIRD, to really start other interventions to help to prevent overdoses.
Great,
And
thank you.
yeah, so other than that, again, within the context of this Linkman study, there are other awardees in the DC, and we have been talking with them to find common areas that we can collaborate and then maybe move jointly to improve the telehealth scene, at least in the DC area.
Thank you for that, Dr. Mete. Thanks all of our panelists. This was a great overview of all of the work that MedStar does in operations, in research on the entire issue of substance use and overdose prevention. So now I'd like to move on again to our panelists, trying to understand what is the scope of resources that are available in the DC metro area if people have any problems with substance use, with overdoses. So we'll try and focus more on what are more concrete steps or what are takeaways that our panelists can share with the community in DC to try and help this problem. So I'll start off with Dr. Levin. Dr. Levin, can you, if you could say one or two main things to people in the community and patients on what they can do right now today on combating substance use overdose, what would they be?
Well, I highlighted a couple of them in my opening remarks, but probably the most important thing you can do is make sure that there's nothing in your medicine cabinet that you don't need. So a couple of ways to get rid of medications are those take back units that I mentioned. And you can Google, there's lots of ways to find where they are located. Many community pharmacies, hospitals, police stations have these mailboxes to get rid of unneeded medications. And also the inactivator packets that I mentioned, you can buy at your community pharmacy. The other really important issue was highlighted by Dr. Amarashi and others, is to have Narcan available for anyone who is at risk for overdose. And so there's a lot of resources as to how you can get free Narcan, again, from many community pharmacies in the area. And there's just a whole lot of information online about who should have it, how to use it. There's easy WebExes to learn how to use it. I think someone referenced an easy video, like a 4 or 5 minute video of how Narcan can be used. So I would say those are the two most important areas.
Great, thank you so much, Dr. Levin. Ian, if you could have patients, family members walk away with one or two things at the end of this panel today, what would those be?
First, as I mentioned before, that as a family member, it's always hard, but there's always hope. There's always hope, but that there are so many resources, whether it's inpatient, outpatient, detox, that you just have. And now it's like Google. I mean, we have it here when a patient comes here and it's at our fingertips, but you hit Google on any of those things and there's so many resources. There's always hope. And as I mentioned again, detox, inpatient, outpatient, sober living facilities, halfway houses, meetings, AA meetings, NA meetings. There's a plethora of information and it's at the fingertips, so that it's out there. Don't give up. And just look for the help and you will absolutely find it.
Thank you for the strong message, Ian. I'm sure that'll be a great hope for lots of patients as well as families. Diana, if we could ask you for what would be big takeaways for patients, caregivers?
I would say you're not alone. I think that's the biggest thing. It can be very lonely and you can be asking yourself, why me? Why my family? And my response would be, you are not alone. Just like Ian stated, there are so many resources, not just in District of Columbia, just Maryland, Virginia as well. I think with the COVID epidemic, one thing highlight of that is all of the online Zoom support groups that are now available. Ian mentioned AA, NA, but there are every day of the week, various times of the day. Such a great resource that didn't exist before. Slowly, there are some that are in person and opening up again, but online is just available to you almost 24/7 now. So that is such a great resource. And just like others mentioned, DC Department of Health does a great job providing community resources, training on Narcan. So I would say also follow up with your provider. If you're unsure what to do, how to help someone, talk to your doctor about it. Several of our MedStar providers are now doing the expert screening in the office, but are also aware of the resources that are available. And then if you're at the hospital, ask for a peer recovery coach. But I think the takeaway message is you're not alone. There is a lot of help out there.
Thank you, Diana. I also want to take advantage of your expertise in community health, in running these programs. Do you have any thoughts about what needs to be done at a community level, health department levels, policy level to try and tackle this?
I really believe it starts with education. So the more you know, the more impactful it'll be. I loved how Dr. Levine says, look at your medicine cabinet. What do you have that you don't need, and how to discard it correctly and safely. So I think it really starts with education. Get informed. All of our peers have brochures, educational materials that we hand out to families and friends. Prevention, if you are at risk or you're concerned about a loved one, have Narcan available, know how to use it. So I would say be informed, and sometimes it's so important to just join these support groups so that you can communicate and talk and learn from others what's worked, what hasn't worked. But then that's also a great way of just learning of all of the community resources that are available to you that you may just never have thought of or knew about.
Thank you, Diana. That was a good comprehensive overview of everything, but it starts from education, and there are always a lot of community resources available for people who are interested in getting more information about the opioid epidemic and just about preventing overdoses in their loved ones. I'll next go on to Dr. Amir Shahi. If you would have any takeaway messages for healthcare providers and patients from today's panel, what would those be?
I think the biggest thing is to encourage our healthcare providers in general to feel comfortable learning a new skill. As medicine evolves, things that we never did before are now quickly becoming standard of care. So don't be afraid to learn a new treatment approach. There are so many resources out there, particularly with how to initiate buprenorphine. There are free courses available. There are some that are very well done through MedStar. Additionally, to keep in mind that patients may not present with an acute overdose, but we screen pretty much everybody that can talk to us. And so if your patient is there for a gout flare, but they tell the nurse that they're abusing opioids, don't be afraid to engage the peer recovery coaches for somebody that screens positive, but isn't there for an acute overdose or intoxication. And then finally, recently, they removed the training requirement to receive a buprenorphine waiver, which is a barrier to providers prescribing it. So it's very easy. I put some resources on how to get a buprenorphine waiver and encourage providers to become familiarized with this medication, because really this is quickly becoming standard of care, and it's something that we can do to save lives. And once again, anybody, even if they're not there with an overdose, if they're high risk, if they're on chronic opioids and they might have accidentally taken too much, give take-home naloxone, because the fact of the matter is that bystander naloxone saves lives, because the amount of time it takes for brain damage to occur when you stop breathing from an opioid or fentanyl is much faster than the time for EMS to get there and to give the naloxone.
Thank you for the valuable message. And thanks also for talking about all of these different treatment options and how it's important not to wait for the overdose event, but to actively screen and intervene if there is a suspected high-risk patient. So thanks for that, Dr. Amir Shahi. And I do see some more questions coming in, so I encourage everyone to just put their questions in. And finally, Dr. Mehte, if you would have 1 or 2 takeaways for community organizers and leaders within DC, what would those be?
As a researcher, I don't have the capacity to touch individual lives, but I would like the community to know that there is a actually well-organized community, especially in the DC area, thanks to the DC government, different departments and other organizations, the research community that tries to understand what is going on and what we can do better. So that's part of the You Are Not Alone team, I think. But the community needs to know that there is a lot of resources and that can be helpful to them whenever they need it. And then they should seek out those resources.
Thank you, Dr. Mehte. Another question that I had was, would you, if people are interested in collaborating on research, what would be the way to moving forward? What areas of research do you think we now need to focus on?
Well, the Linkman study is a very good example that there is a clinician here, Dr. Amishai, who has brilliant ideas about what can be done better. And then she contacts and she collaborates with the researcher who has more time to invest in writing proposals and just getting those ideas out to support them. I think that's a good model. And anyone who's interested at MedStar or outside of our MedStar can connect us. And then if we can find time and the resources to conduct the study together, that's a win-win situation. So I encourage everyone who is able or who's interested in doing that to contact me and see if we can do better things together.
Thank you, Dr. Mehte. I will quickly transition to a couple of resources that we have put together that are available in the DC area for patients, families. Zoe, would you mind pulling up and sharing the slides so we can just put that in? And we'll also open this up for general questions in the meanwhile. So the DC government has this campaign of Live Long DC. If you text that to 888-1111, you can find naloxone kits that are available throughout the district. In addition to that, there is also a helpline by the DC Department of Health. We've listed the numbers over here, and what Dr. Levin was talking about, the medication take-back programs. Again, these are widely distributed and dispersed throughout the DC area, so we can make these slides available to people later also. If you go to the next slide, Zoe. In addition to that, we also have lots of medication-assisted treatment centers in DC that specialize in treating patients with opioid use disorders. So we've listed a couple of names over here, namely PIDAC, HIPS, as well as Unity Healthcare. Again, I'm reminding people that we can share these slides. Just email me. I have my email listed at the end of it. You can go to the next one, Zoe. And then finally, we have a whole list of different treatment options that have been made available by SAMHSA on guidelines that practitioners can use to prescribe medication-assisted treatment and medication-based therapy in general. I'm just going to come back to information, my contact details in the next slide. If you have questions, feel free to email me. It's my first name dot my last name at medstar.net. So I'm going to go to the first question. This is about medication-assisted treatment, maybe for Dr. Amir Shahi or Dr. Levin. How long are people typically on MAT, and how can employers support their staff and peers who are on MAT for medication-assisted treatment?
I can gladly take that. So for medication-based therapy, which essentially we're talking about the buprenorphine and methadone treatment, which are opioid agonists. There are other treatment options such as naltrexone, but those aren't as common. So when we look at the evidence for the use of these medications, is that most people do better long-term if they are on maintenance therapy versus acute detox, where they do like a rapid taper. And the importance of that is that we know that these people do better, although they may have preferences for acute detox because they don't want to be, or there's stigma associated, or they're concerned about their employers. So it's a very personal, individualized decision. There are patients that are on these therapy lifelong and they do fine and they have a completely normal life on these medications and can function completely normally. So really it's as long as the patient really feels they need it or there's no contraindication to it. Some people do try to get off the medication after they've been stabilized for some time, and that has to be done very carefully because of the risk of relapse. So they may very slowly titrate, or sometimes they may switch between the two medications. So for example, if we can get patients down to a lower dose of methadone, they may want to transition to buprenorphine because it's not as inconvenient as to have to go to a clinic every day. So the answer is months to years or the rest of their lives, depending upon the individual. And that's the best answer that I can give because it is a very individualized decision, and it's based on a lot of factors, particularly risk of relapse and are they tolerating the medication. How employers can help support people is number one, I think they need to have a carve out with regard to drug testing. There are ways that we can detect if patients are using other opioids or diverting their medication-based therapy. We can tell that on a urine screen. So if that's something that they need to periodically check in with their employer or periodic drug testing, it shouldn't be an exclusion to any form of employment necessarily.
Thank you, Dr. Amir Shahi. I know we're getting close on time. I'm going to close with one last question to Diana and Ian. Do you have recommendations on how healthcare systems can incorporate peer recovery coaches into their care team? What would be steps that we could do that?
Sure, absolutely. So as part of our implementation of the new SBIRT program in any setting, inpatient, outpatient, emergency department, we introduced the concept at several team meetings. So all of the shifts that have team meetings, we come in, we introduce the concept, we explain the roles. Once the peers have been hired, we go back and talk about now we're going live, we introduce the peers. Absolutely, there's some hesitancy. How is these non-medical individuals going to help us? The biggest compliment I would say to this program is watching the clinicians, regardless, nurse or doctors or residents, come and talk to the peers about, street drug names or how things conflict or how the peers were able to get so much more information that's beneficial and that the clinicians really need to understand the next treatment care for the individual. So yes, there's ongoing, there's an introduction during implementation. We introduce at every shift so that everyone becomes acquainted. We integrate the peers. They're stationed within the emergency department alongside the nurses. And then we continue doing booster trainings. So it's an ongoing focused effort to make sure that the peers are feeling welcomed, that they're integrated, and that the clinical teams feel like they are a valuable resource.
Thank you, Diana. That was great, and it gave a really good example of how peers can be integrated more organically into the provider team and how gradual interaction with the peers really helps with their job, the important work that they do. So thanks again, everyone, for joining us today. It was really great hearing about your expertise and the work that you do at MedStar Health on substance use and overdose prevention. Thanks the audience for joining us today. If anyone has any questions, please feel free to email me. It's my first name, sadaf.mylastname@medstar.net. So thanks again and have a good rest of the day. Bye.